including the people at the back. Thank you. Obviously, we still have, whereas I gave the doctors in training a gold star for being here promptly this morning, and now none of them are here. So they're obviously still at their candidate briefing. But I think, nonetheless, we're going to get very behind time if we don't get underway now. So I'm going to hand back to Bev.
Thanks, Anne. Well, it's a pleasure to be introducing our next speaker, Professor Vlado Perkovic from the National Health and Medical Research Council. Vlado is Executive Director of the George Institute Australia, Professor of Medicine at University of New South Wales, Sydney, Staff Specialist in Nephrology, Royal North Shore, and a member of the National Health and Medical Research Council Principal Committee. Professor Vlado will talk about how clinical trials better inform healthcare, and we would also like to acknowledge the sponsorship of NHMRC. Would you please convey our thanks to that body? Welcome.
Thanks so much, and thanks for the opportunity to come and speak to you today. When I was leaving home this morning, my wife said to me, "What on earth are you doing flying down to Canberra to give a 15-minute talk on a beautiful sunny Saturday, rather than being at your son's Aussie Rules football game, which is where you should be?" And I agreed that that seemed silly, but I said, this is a really important thing. And my view is that talking about randomised trials is probably the single most important thing that I do. And I'll explain to you why, but just to make sure you're all awake after your lovely lunch break there, let's see if we can run a little trivia contest. Who can tell me the name of the organisation who runs the greatest number of randomised trials in the world? Any thoughts? The answer is Facebook. Facebook and Google is number 2. Those two organisations run randomised trials on every element of everything that they do. If they're thinking about changing an element on their website, they'll randomise it. They'll randomly deliver one version to half the people and another version to the other half, and they'll assess which one has the greatest impact. And they use that methodology to tweak and refine every aspect of what they do, because they understand how powerful and reliable randomised assessment is. And it's the same in healthcare, obviously. Clinical trials are absolutely crucial to optimal healthcare. And we really need every person here to be an advocate for randomised trials. They're essential not only for evaluating new drugs. We all have heard, and there's a lot said about drug trials, and both in a positive but also sometimes in a negative sense. But that's only a tiny, very narrow part of the broader community of randomised trials that help inform the things that we do. Looking not only at drugs, not only at new drugs, but also old drugs, looking at devices, looking at fluids, looking at every type of healthcare intervention, and helping us understand how we can provide the best quality healthcare to our patients, and particularly how we can avoid inadvertently harming our patients. And there are plenty of examples where we've all done that. I suspect many of the people in this room have, in good faith, advised patients to have hormone replacement therapy, because up until about 10 years ago there was evidence suggesting, shouldn't use the word good, but there was observational studies suggesting that people who took hormone replacement therapy had a reduced risk of heart disease. And once the randomised trials were done, the high quality randomised trials, we learnt that the reverse was actually true, as well as the effects on other outcomes like breast cancer. So randomised trials are crucial. So we need to focus on the impact of randomisation. Randomisation is important because we can do observational analysis where we adjust for a whole range of factors, but we can't measure everything and we can't know everything, and we learn things as we go. So by randomising patients, we balance known and unknown factors, and we're often surprised by the effects of various interventions. We've learnt in recent years that the diabetes drugs that are now being widely promoted and widely used have very different effects One class, the DPP-4 inhibitors, lowers glucose, but has very little impact on cardiovascular disease or kidney disease. The other class that's recently been introduced, the SGLT2 inhibitors, have a similar effect on glucose, but dramatically lower the risk of death, heart failure and kidney failure. And we wouldn't have known that based just on their glucose-lowering effects, and it's only the fact that we've run the large-scale randomised controlled trials that we've learnt that. Blinding is also clearly important. Renal denervation is an example of where unblinded trials led to an overestimation of the potential benefits. So where we can, double-blind randomised trials are the only truly rigorous and reliable way to understand the effects of various interventions. And we've been running clinical trials and randomised trials for a long time, and Australia is a world leader in this area, both in the design, the oversight and the conduct of randomised trials, and we have more than 1,000 randomised trials running in the country at the moment. There's a huge number of significant medical breakthroughs. There's some really powerful stories from people who've been impacted by the recent development of melanoma drugs. We've had people like Ron Walker, who unfortunately recently passed away, but who, when he was diagnosed with metastatic melanoma, flew to the US to participate in a randomised controlled trial, one of the first randomised trials of immunotherapy, and was able to achieve several additional years of healthy life as a result. Access to these sort of treatments is important. We've seen important trials help us understand what sort of fluids we should provide in intensive care. Most recently, in the Clinical Trial of the Year Awards here in Australia that were awarded in Melbourne recently, we saw the perinatal groups across the country report a trial where they compared immediate cord clamping in premature babies to delayed cord clamping, where people would just wait 1 minute, 60 seconds, before clamping the umbilical cord of newborn babies. And we saw a 33% reduction in the risk of death in hospital for those premature babies who just had their cords clamped a minute later. Again, incredibly powerful and important findings that were delivered through these sorts of randomised trials. So trials help us get the best evidence for the impact of various outcomes. They help provide access to new treatments early on to people who really need them. They also help us develop our healthcare system more broadly, all leading to better outcomes for patients and greater efficiency. We need to make sure that as a group of thought leaders, as a group of advocates for better patient care, which is something the AMA has always been very strong on, we recognise the importance of randomised trials, that we are advocates for them, both to our patients but also to our colleagues, students, trainees, administrators and others. It's important to understand and use them in terms of their results, but also where appropriate and possible participate in them or lead them with appropriate support, and we've got fantastic clinical trial centres across this country. In order to help raise the awareness of the role and the value of clinical trials, the NHMRC has developed the Australian Clinical Trials Campaign. And you'll see this, hopefully, over coming weeks and months and years, rolled out across a whole range of channels and using the headline of Helping Our Health. There's a website that's been created, australianclinicaltrials.gov.au, and I'd encourage you to go and have a look at that, and also to visit the booth in the hall downstairs where Samantha will be awaiting your visits with great enthusiasm. But really, this is crucial for all of us, for all of our patients, and I hope that you individually and the AMA as a group will support this approach. Thank you very much.
Well, thank you very much, Vlado, for an excellent address on the value of clinical trials. Okay, we'll turn now to our policy session. And during the break, I've been lucky enough to obtain a tutorial from our visitor from the British Medical Association, Andrew Herndon. Thank you, Andrew, for coming to our rescue. So Andrew represents the country which did bring us the Greenwich Mean Time, reliable railway schedules and the rules of parliamentary debate, so I'm delighted to take advice on how the BMA gets through their very lengthy list of policy discussions at their meetings. So with everybody's permission, I will vary the times because, 20 people have put together policy motions for us. So 3 minutes for the presenter, and realistically everybody has been under 3. 2 minutes for the speakers, and we'll ask shortly after debate starts when people are ready to vote. So we won't exhaustively take every speaker to the microphone once the mood of the debate becomes clear. I again remind you these are advisory motions, so they will go to Council, and even the near misses are on the watch list for Federal Council. So, life will not end here today for these policy positions. So can I ask everybody to be ready to come to the front of the room, because we're going to move the order of the debate around a bit depending on who comes back from the candidate briefing sessions. And I'm wondering if Ross Kerridge is here. Yeah. So Ross, you'll be up next, followed by Jeff Hawson. So the topic is the role of GPs in providing long-term health care. The draft motion is that, noting the AMA's position statement on general practice and primary health care, our AMA should further investigate how Medicare could be redesigned to support the central role of GPs in providing long-term health care, and 2, examine the current incentives in payment for care and how addressing these incentives could further support long-term system sustainability. Thank you, Ross. And this is seconded by Michael Bonning.
Yep. Okay. There's an old saying that I was told many years ago: if the patient has a good GP, a hospital specialist may be able to help them. If the patient doesn't have a good GP, nothing can help them. I'm an anaesthetist in Newcastle. My interaction with general practice is perhaps more than most anaesthetists, in that, until very recently, I was the supervisor of the pre-op program. And a remarkable thing that has always struck me, that patients being prepared for elective surgery, that we can say to the secretaries or to nurses, right, get on to the GP, get a summary from them, get as much information as we can from them, and it would come back. And the summaries would come back from many patients. And sometimes they were great, sometimes the quality was patchy, sometimes they didn't come back at all, particularly from corporate practices. But while this is an extraordinarily valuable thing for me, and more broadly for the patient's healthcare, the GPs aren't remunerated for providing that service of ongoing care, of coordinating care, of maintaining a record, a summary record of the patient's health status. That's in our current system. And so the really valuable service, the most valuable service that the GPs provide, is not rewarded. This is particularly apposite at this time because there is flux in the political situation. There's a great degree of uncertainty about who will win the next election anyway, and regardless, both sides are looking for solutions. We heard Greg Hunt yesterday talking about introducing a quality care framework incentive system for general practice. We have practice incentive payments. We have the hospital in the home trial, which has really been a bit of a mess. And on top of the lack of reward for the good stuff, there's currently a whole lot of perverse incentives that the corporates are really brilliant at exploiting, but they still don't provide long-term care. So the patients will have had all sorts of little tick boxes ticked with minimal amount of care, enough to justify the billing, but the long-term care of the patient and the long-term maintenance of the health record isn't there. The fee-for-service system is good for providing a service. It needs to be examined and redesigned. There are various possibilities. I have my own view that it can be simply done. We can maintain the fee-for-service structure, but build on a new item that actually rewards long-term care, and with some specs about that. But whatever the answer is, the AMA should be providing leadership for this together with the College of GPs, ACRM and other GP groups, to actually develop some policy ideas to put to the government rather than let bureaucrats develop them themselves. Thank you.
Yeah. Thanks very much, Ross. Now, if there are speakers, I'd ask those who are supporting the motion to go to microphone 1 and those who are against the motion to go to microphone 2. And they're the only microphones we'll be using. And if you could decide early if you want to speak, because we won't be waiting for lengthy red carpet entries. All right, thank you. Microphone 1.
Thanks. So I'm Dr. Ken Singh Lim. I'm a general practitioner in Western Sydney, and I'm speaking in support of the motion. So the big difference between now and when Medicare was first developed is that the nature of general practice has changed. The job which needs to be done has changed. And there's much more focus now on chronic disease management, and what can be done in a team-based environment is very, very different. The problem is that funding drives behavior. So if the current model of funding, the way it is structured, drives a certain type of behavior, hence that drive towards volume rather than value. So if we want to use these funding structures better, we first need to have a model of care. So I'm speaking in support of the motion for 2 reasons. One of them is that we actually need to develop the model first, and we need to have a model of quality which allows us to then direct the funding to support that model of quality. And the second one is that this has to be an evolutionary model. So we have many things built in our system which currently work. It's not about throwing all of those bits out, but about how we build that to make our system better. Thank you.
Thank you. Microphone 1.
Thank you, King Singh. My name is Ines Rio. I'm a GP. I'm chair of the GP section in Victoria and also on the AMA Council of General Practice. What I love about the AMA is that was actually moved by an anaesthetist, so thank you very much, Ross. I'm strongly supportive of the motion. I reinforce everything that King said. Of note, yesterday both Catherine King and Greg Hunt actually alluded to the fact that we will in the future have a different payment model that drives quality, and we need to actually define what that model looks like. If we leave it, it will actually be defined for us. Thank you.
Thank you. We'll go to microphone 2 if you don't mind, cameraman, and thank you.
Hi, Mark Heads, Ballarat. I'm not sure that one can stand up and oppose what sounds like a motherhood motion to me as a geriatrician. I am concerned, though, that we are, having just said that and I presume Medicare doesn't mean the department, it means the Medicare benefit schedule. I'm not sure about that. And I'm presuming that long-term care doesn't mean residential aged care, which is what it does in common parlance, but then perhaps this is written by an anaesthetist. So the problem I've got with this is that are we saying that we want general practice to actually be supported by the MBS item numbers, and I don't think we do.
Thank you. Microphone 1.
Dominic Barbara, GP Victoria. I strongly support this motion. We are doing a lot of work in general practice and not getting paid for. And when we do get paid, in fact, it is very important to make sure that the money goes to the GPs and not necessarily to the practice. I think this is an important issue, particularly now that we have lots of corporatised practices. The Medicare item number is in the name of the GP. The money is paid because of the GP work, but the money goes to the practice eventually, and the GP might not get very much. So it's not only important to make sure that we are paid for the work that we're doing for nothing, but that it goes paid to the GPs themselves.
Thank you. Last speaker.
Thank you, Paul Leskins, GP. I support the motion because I'm standing next to number 1. I just think it's a useful time to reflect on the fact that yes, GPs should be the centre of care and the coordinators, etc. We all know that, and we should be saying that until we're blue in the face. I do have reservations about this temptation to think that Medicare has to be the driver of quality. We choose to be professionals and to be doctors, and for that reason we make a commitment to quality whole patient care. And I think if we lapse into this business of thinking the MBS and Medicare is the driver of quality care, well, we're being a bit soft. So yes, I support the motion, but I think I also would like to take the point that we should all be committed to quality care without Medicare. Thank you.
Thank you. All right. Any final comments, Ross? No. Thank you. Could you wake up your voting devices by just pressing any button? And the motion is on your screen. And voting is open. Thank you. Oh, is that, yeah, that's the one. Voting is open. Oh, so no assistance. Yeah, I'll call that. Yeah. And the motion is carried. Thank you. Next, we'll go to Jeff Hawson. And could I ask speakers to other motions to come to the front row so that we haven't got time being utilised in just getting in position. So this is the topic on page 92, a survey of members' attitudes to limited registration and transition to retirement. The draft motion is that our AMA undertakes a nationwide survey of members to ascertain their views on limited registration in transition to retirement, at the scope of practice for limited registration, the registration requirements, recency of practice, definition of practice, CPD, and the potential range of practitioner contributions to the profession in transition to retirement. Put by Professor Geoffrey Hawson, seconded by Kimberly Bonderson. Thanks, Jeff.
Thank you. After working life for some 30 to 50 years and approaching retirement, it can be a case of feeling like from a rooster to a feather duster overnight. Many practitioners hope for a period of slowing down with the ability to use their skills in the process, possibly to help apprentice and train those more junior than themselves, or to make a valued continuing contribution to the profession. Current guidelines do not support a transition to retirement model, nor scope for any practice once retired, unlike other professions such as law. The APRA guidelines indicate that when retired, medical practitioners are not to practice medicine. Defined, practice means any role, whether remunerated or not, in which the individual uses their skills and knowledge as a health practitioner in their profession. For the purpose of this registration standard, practice is not restricted to the provision of direct clinical care. It also includes using professional knowledge in a direct non-clinical relationship with clients, working in management, administration, education, research, advisory, regulatory or policy development roles, and in any other role that impact on safe, effective delivery of services in the profession. Recency of practice, registration types and the definition of practice are of concern to many practitioners. Cognizant to the concerns to members of the Redcliffe and District Local Medical Association, we organised a survey that went to Redcliffe, Brisbane North and the Sunshine Coast. In brief, and there's some more details in the actual document, 131 people replied, a 21% response rate. Over 70% were concerned with loss of registration privileges on retirement and believe that a limited registration should be available. There should be referral rights to specialists and pathology, and also believe that there should be continuing CPD involved in this process. Our results indicate that there's a grassroots concern over the current practice guidelines, which offer an all or nothing approach. I believe the AMA membership has not had a chance to have their say in these matters. If our sample reflects the views of AMA's national membership, then I believe it is imperative that the AMA takes action to address these concerns. It is possible to ignore the members' voices if we are not given the opportunity to speak, but we deserve the right to be heard and represented by our elected colleagues for what we the members believe, not what the executive believes we believe. If that is not done, the AMA will continue, as we've heard many times this weekend, to shrink in numbers, and it will go the way of the Tasmanian tiger. So I encourage you to support this motion.
Thank you, Jeff. Speakers for the motion, microphone 1. Speakers against, microphone 2. For those who are late into the room, we've adopted some of the strategies used by the BMA, so you'll...
For those who weren't paying attention before, I'm Wayne Hurdy. I'm a GP from the Sunshine Coast. I want you to remember that this motion is not about solving all of the problems of retired and semi-retired doctors. It's not about discussing whether somebody is okay to practice if they write 2 prescriptions a year. We're not discussing that. What we're discussing is this a proper thing for the AMA to put its resources into? I had the privilege of being on AMA Federal Council a few years ago when this came up, and it was decided then that AMA Federal Council was not going to attack this issue, and part of the reasoning was put by the Treasurer, who said these retired doctors don't pay subscription fees. Ladies and gentlemen, I remind you that these retired doctors paid subscription fees for the last 10, 20, 30, 40 or even 50 years, and they looked after the AMA for a long period of time. It's time for the AMA to look after them. The second thing that arose recently is I spoke to one of my colleagues in Queensland. I said, look, this is a live issue. And he said, no, it's not a live issue. This is dead and dusted. This survey shows that according to a significant number of doctors in one area of southeast Queensland, this subject is not dead and dusted. It is a live issue. Ladies and gentlemen, this debate today is for you to determine whether the AMA Federal Council should still regard this as a live issue, as I believe it is.
Thank you.
And I'm Kimberly Bonderson. I'm the President of Redama, and I'm also on AMAQ Council. I'm a general practitioner from Redcliffe, and I support the motion. I wouldn't be standing here today if it wasn't for the surgeons, the retired surgeons that came in and taught us in medical school in our anatomy. These people have so much to offer us, and it's ongoing. And I think that taking away the ability for them to just slip into those roles, which is what has happened, I think it's imperative. We have to change that. That's just not correct. And I support the motion.
Thank you. Thank you.
Rob Parker, Northern Territory, and putting on my psychiatrist's hat for a moment. There's a real potential problem looming for mental health tribunals and the levels of expertise required from psychiatrists who work in tribunals, many of whom are on the verge of retirement. And I think unless the AMA takes an interest in this, it could have a major impact on the ability of psychiatrists to work in mental health tribunals and the resilience then of mental health legislation that protects people with severe mental illness.
Thank you.
Dominic Barbaro, Victoria, GP. I strongly support this motion and I'd like to repeat what the previous speaker said, that as an AMA member for many, many years now, I expect the AMA to be there present in discussions with the authorities who may not introduce limitation to my practice as I'm approaching my retirement age. And the other thing to take into consideration is the fact that as we get older and we work part-time in a transition to full retirement, we also have that ability to select which patients we are going to treat and see, and I think we need some assistance there. So if any examination or peer review or whatever it is that might be introduced, it has to take that into consideration, that if we do work in an area that we don't want to work, if we are requested to be brought up to date in an area that we don't practice, I think it's a useless exercise. It'll be like the PhD required by the young doctors.
Thank you.
Jeff Dobb, a public hospital doctor. I think the issue here is really with the very broad scope of the limitations of practice after retirement, so that the ability to continue to participate in research and so on is a very real issue, particularly when grants run for many years. What I would favour is a re-examination of the very broad restriction that there is on practice at the moment, and to re-evaluate that. Point out, of course, there is no compulsory retirement age for doctors, though interestingly there is for judges. But even after retirement, judges, many of them go on to run royal commissions, sometimes very well. Thank you.
Thank you.
First thing I want to say is that Wayne talked, I think I was the dead and dusted person, is that? As you can see, I'm not over there, I'm over here. Mainly that's because there was more talk about being able to do things without the CPD, but I think the motion is very, very well worded, and it does include all that sort of stuff. I think it's absolutely important. I am certainly working towards retirement at the present time, so it's important for me as well. But I also have the view that if you want to retire, you should be allowed to retire, and you do not have to be a doctor if you don't want to be after you've retired. But if you do, then we should certainly try and put together something that will allow you to do that.
Thank you.
I'm Sarah Whitelaw from Victoria. I'm not currently working towards retirement, but I see this as core business for the AMA. The more colleges I talk to, the more they are all developing their own individual transition plans, working towards helping their doctors transition into retirement. We are the only body that is in a position to actually work on behalf of all of these different specialties, and I guess omit duplication in a way and assist our members across the profession. And it appears to me that this would be one of the key services that we should be promoting going forward as a role that only the AMA can undertake in the profession. So I very much support the motion.
Thank you. Now, anything further to say, Jeff?
Just briefly, don't believe our survey, replicate it nationally and take note of the results either way. Thank you.
Thank you. And the motion is up for voting. Voting is open. What's that? And the motion is carried. Thank you. Well, now I apologise to the returning officer up the back. Some of our speakers are back, so Tessa, can I ask you to come up? Next topic, gender equity. The draft motion that, noting the AMA position statement on sexual harassment in the workplace 2015, our AMA establishes practical recommendations that could be implemented into the healthcare system to address the underlying systemic factors that impede the health system's ability to adequately address gender equality. Draft motion moved by Dr. Tessa Kennedy, seconded Brad Frankham. Thank you, Tessa.
Thank you, Chair and the room. So gender inequity remains a significant challenge within the medical profession as within much of our society. No doubt in recent years there's been a lot of cultural shift in recognising the importance of equitable and diverse participation and representation, but we've too often assumed that just by saying gender equity should happen, that it somehow will. This trickle-up approach unfortunately hasn't worked. We've had gender parity among medical students since 1990, yet progress to parity at supervisory and leadership levels has stalled. There are large gender pay gaps for equally trained and skilled professionals in all craft groups. And even when women doctors are primary breadwinners for their families, they tend to shoulder a greater burden of childcare and domestic work. So what of all our best intentions? We know that young people now broadly hold very equitable ideals for how work and family demands should be shared. Yet the literature suggests that equitable expectations are derailed when they start to clash with workforce policies, which remain rooted quite heavily in traditional gender norms, which are most obvious, particularly when a couple comes to have a child. Existing policies ensure that the path of least resistance is the traditional one, for women to take the majority of responsibility for childbearing and rearing, while men remain fully engaged in the workforce. And unfortunately, the gap just widens from there. Common problems with current workplace policies, and therefore targets for change, include inequitable parental leave, specifically almost non-existent paternity leave, lack of support for return to work and lactation practices, lack of accessible childcare, especially to meet the demands of shift and on-call workers, inflexible training pathways and inequitable access to flexible training arrangements, lack of access to relief cover for employees on parental leave, and a requirement for individual departments to recruit and fund any such relievers. So to be clear, this is not a women's issue. These inequitable policies sell us all short and undermine our very best intentions to achieve gender equity every step of the way. So let me offer a brief case example. In August, my partner and I are expecting our first child. Note, I say ours, not mine, as beyond the very brief parts that truly only I can achieve, the baby will be our equal responsibility. Now, I'm a registrar entitled to 14 weeks of paid maternity leave through a public hospital contract and up to 12 months of total leave. I consider that to be pretty good. Luckily, I'm a paediatric intensive care trainee, but if I were a surgical registrar and went on parental leave 5 months into a 6-month rotation, those 5 months wouldn't count towards my training. If I was an obstetric gynecology registrar, I'd potentially have a fixed 4-year contract in line with length of training, but where maternity leave counts as contracted time, which runs out before I actually complete my training. And then it's hard to find a 1-year contract to make up that final year because most other trainees are in 4-year contracts and the institutions don't offer them. Now, if my partner were a doctor, he would be entitled to just 1 week of paid paternity leave, so there isn't much support for him to take on parenting while I get back to my career. So I'd probably end up taking a longer period of leave or returning part-time or some other such low resistance option to achieve what we wanted to for our family. Luckily, my partner is not a doctor. He happens to work for Google, a company that has prioritised gender equity as part of its professional culture and uses its systems to create this ideal. While there are many parts to this, given that childbirth is a common point where gender inequity really begins and from there it widens, equitable parental leave is a very tangible first approach to its resolution. As an example, at Google, every new parent is entitled to 3 months of paid parental leave, rather similar to my entitlement. However, if you are also the person giving birth to a child, you get an additional 6 weeks of paid recovery leave. To me, this neatly defines an equitable workforce policy. It recognises a biologically imperative difference in our responsibilities, and it doesn't overstate it. It seeks to enact equality wherever possible, but recognises that equity is the most important paramount achievement. Practically, it means that my family is going to be able to realise our aim of more equal parenting and workforce participation. I'm going to return to work full-time in ICU after 6 months and get on with a second fellowship training, while my partner not only supports me in that transition, but upskills to be an equal parent and home life participant in years to come. Our culture will be defined by the system in which we exist. So to achieve the change that will support equitable participation and work-life balance in our profession for all of its members, not just its women, the AMA must recognise existing systemic barriers holding us back and recommend such practical strategies as to overcome them. I commend this motion to you.
Thank you. Now, the doctors in training were still out of the meeting when I introduced the new rules so we can get through the debate. So all those speaking in favour of the motion, please go to microphone 1. Those against, go to microphone 2. And we will call a close to debate if we think there's a mood ready to take the vote earlier than total exhaustion of all speakers. So, okay, microphone 1.
So I'm Sarah Cole, orthopaedic surgeon from Cairns. I'm only speaking to this motion because it occurs to me that there may be some people in the room that could possibly contemplate voting against this motion. This is a no-brainer for me. I agree, I'm not here for gender equity, I'm here for the role of the parent in medicine. It occurs to me that Barnaby Joyce doesn't appear to look like he knows how to hold a baby, and I think that's our problem here. There are people in this room that don't know how to hold a baby, that don't know how to nurture children, and I don't think I want my doctor to not know how to nurture a child. I want my doctor to be at home with his family when he needs to be. I want my doctor to know what it's like to be up at 2 o'clock in the morning with a sick baby and how horrifying that is, and try and turn up in the morning and try and tell himself that he's okay to practice and that he's safe.
Okay.
When we look around the room and the people in the room look like us, we need to consider our measure of merit. If everyone looks like me, then my measure of merit is not valid. The room needs to be diverse. If I have to hear one more man bemoan the risk that a good quality, talented man might miss out on a position because of gender bias, then I think I might scream. Thank you, guys. I've had that said to me twice in the last month. It's 2018, 50% of my year of medical school were women. Where are they? Why aren't they in this room? We need to seriously think about what we're doing here and what kind of organisation we want to be. Thank you.
Thank you.
Brad Frankham, AMA New South Wales. I seconded this motion. I obviously want to support it. And just note that the motion is to develop practical recommendations. That's what we're asking for here. In AMA New South Wales, we actually put out an email last year after hearing reports of highly discriminatory questions being asked in job interviews. And we got a barrage of emails back predominantly from our female members about all sorts of inappropriate questioning and pressure being placed on them by the system, particularly with regards to child rearing. And so this is a live issue. It is going on as we speak, and that's why I think AMA needs to support this recommendation. Thank you.
Okay. Yeah. Now, how many speakers have we got? Because I think probably the mood of the room is there's nobody on this side.
No. I'd like to make a really important issue, though, if you don't mind.
I'm sorry?
I'd like to speak just briefly.
Okay.
Ines Rio, thank you, Tessa, for moving that. And I just think that I'd like the group to become aware of a really important issue, which is if you're a GP registrar in Victoria, you move every 3 to 6 months. You don't get 14 weeks of paid maternity leave. You don't get 1 week of paid maternity leave. You get no paid maternity leave. As you move around every 3 to 6 months, you lose every bit of your sick and carers leave. So you start off with 10 per year, 10 days a year, but as you move, say every 3 to 6 months, you lose it. So you only ever accumulate 2 to 4 days. This is manifestly inequitable and unjust. So I'd like to put it to you that when these recommendations are being developed, that you don't forget the other doctors in training, which are GP registrars. Thank you.
Thank you. I'm keen to truncate debate, but if you've got something special, you know, something you don't think we've covered, or...
I'll be very brief. Apologies for getting up again, but I can't sit down for this one. I'm glad we're having this debate on this motion. I think it's time, and I think it's time. It's time to have the difficult conversations and really look at the difference between our policies and what actually happens on the ground. I think the solutions required are much more complex than pushing for cultural change or even than discussing bias, whether that's unconscious or conscious. I believe that most doctors support every single word of our position statements, yet discrimination still occurs every single day. And we need to ask why. We need to ask the difficult questions. Why do directors of units find it difficult to hire young women who might go on to have children? The difficulties of obtaining backfill, of recruiting and replacing doctors who go on leave, and the additional time and administration required to facilitate job sharing needs to be acknowledged. These are barriers. We need to direct practical assistance and resources appropriately to remove the actual barriers to facilitating work-life balance. This is a principle that we all know is required by all of us, not just younger women, not just to be better parents, for our mental health, and to be better doctors for our patients. Instructing the profession not to discriminate and to aim for gender equality is no longer enough. We have to address the practical barriers that stop our profession from discrimination and achieving gender equity, and in so being the best profession that it can be.
Thank you.
Xavier, radiologist and younger fellow. I'd just like to commend the Doctors in Training for putting up this and say it obviously applies to Doctors in Training, but also to younger consultants who are looking to start a family. So thank you, because it gives me confidence that I may be able to spend more time with my future child. So thank you.
Thank you. All right. Well,
sorry, Chris Wilson,
my reply
physician.
time.
Look, I think I'd just like to challenge us as an association to think about the barriers that we have in terms of leadership. You know, this is not just a workforce issue, and it's the middle tier barriers that we should be looking at. Why don't we have more female candidates putting their hand up to be a president? Why have we only had 2? The AMA can lead on this, but we have to look at ourselves first. Thank you.
Thank you. All right, are we ready to take a vote? Nothing left, Tessa? No?
I can talk forever, but don't make me.
Thank you for not doing that. Okay, the motion is on your screens. It's open for voting. Do you want to sit down for a minute? Or do you want a chair? Okay, the motion is carried. Thank you. Because the Doctors in Training were late back in, can I just reiterate the change in rules, which I hope you'll indulge me with, because 20 people have put work into their motions, and I'm very reluctant to knock anybody off the end of the schedule. So advice from our visitor from the BMA is that the BMA truncate debate at about 15 minutes once the room is ready to vote. So no matter how many speakers there are, if there is a clear mood, then voting can take place. And that works particularly well for us because these are advisory motions. They're not, you know, drop-dead motions whereby we have to get all the wording right. So, with your indulgence, that's how we're doing it. And I introduce our next topic. Do we need to take a stronger stand to stop discrimination in recruitment, employment and flexible work practices? The draft motion that our AMA reiterates its support for equal opportunity in the workforce, calls on in the medical workforce, calls on employers, medical associations, the learned colleges and members of the profession to commit to developing and disseminating clear, comprehensive and consistent information about employer obligations, employee rights and leading practices and strategies in relation to pregnancy, parental leave, return to work. And B, identifying and removing harmful stereotypes, practices and behaviours about pregnant women and working parents to eliminate discrimination related to pregnancy, parental leave and return to work. Moved by Dr. Tessa Kennedy, seconded Dr. Jill Tomlinson. Thank you, Tessa.
Thank you. Thank you for indulging the second part of the gender debate. Anyway, this is a different issue. I suppose we've tried to frame the first one as systemic factors, and and this is more of a discussion of culture. So I think that it's disappointing that despite a commitment from the profession and workplaces to equal opportunity in the workplace, that in 2017 the New South Wales Doctors in Training Committee received concerning reports that trainees were being asked inappropriate questions in both formal interview and pre-interview settings, from the explicit to the implicit. Are you married? When are you planning to have children? You are clearly with child at the moment. How do you plan on working this job? I'm sorry, how does that relate to the selection criteria? But on further consultation with trainees, it's clear that the entrenched gender discrimination, particularly in relation to planned or possible childbearing, is actually much more widespread. It pertains to career advice, and I use that word rather loosely. This specialty will be too demanding when you have children. You'll want to do something more flexible. As a mother, you'll never get on this program. We won't be renewing your contract. We don't want to set a precedent in this LHD of people taking maternity leave. These are all verbatim quotes from trainees who have emailed me regarding their concerns with respect to gender discrimination in our system in the last 12 months. A previous CDT chair of ours was even asked during an interview for a retrieval job if her spouse approved of the employment, given how dangerous it was. Moreover, rather than helping to change these practices, we've discovered that a number of training supervisors who were actually reported to be complicit under the guise of being pragmatic, suggesting that married women remove their wedding rings before interviews, suggesting that if a trainee should be asked questions about pregnancy plans, that they simply deny any such intentions, regardless of evidence to the contrary, and instructing female trainees on how to provide these right answers to the wrong questions, while simultaneously being unable to conceive that any male trainee might want to take a substantial period of parental leave or access flexible training arrangements as a primary caregiver, goes on to support this entrenched culture of gender discrimination, which we are all responsible for calling out and updating. It speaks of conscious and unconscious bias, which we need to recognise if we are to truly and effectively address. Now, it may surprise some of you to know that in collating the reports I receive from trainees, the most common offenders with respect to overt discrimination in recruitment, particularly in relation to pregnancy, were among adult physician training and obstetrics and gynaecology interviewers, with general practice also rating a notable mention. Funny that these seem to be touted as the most flexible and supportive of our female trainees. Conversely, the College of Surgeons, which has one of the greatest gender imbalances among their trainees, is probably demonstrating the most insight into their barriers and into their problems, hopefully, of the past, by trying to provide leadership and positive action in this area. I was really heartened to hear of an incident last year involving an inappropriate question being asked at a surgical subspecialty interview, and it being met with appropriate concern, reprimand, and removal of that individual from any future recruitment processes. This is the kind of action that should be happening everywhere. It's important that the AMA makes clear that we will not tolerate discrimination in the medical workplace and encourages actions to speak louder than words and position statements in creating truly equal opportunity in the workplace and allowing flexible work practices to support all working parents and trainees, because frankly it's 2018. I call on National Conference to support this motion.
Thank you. Those who are speaking for the motion, microphone 1. Those against, microphone 2. And could I ask Steve Kisley to come down? We're varying the order again, so you're up next, Steve. Okay, thank you. Microphone 1.
Thank you. Jill Tomlinson, plastic surgeon from Melbourne. I rise to speak in support of this motion. The ongoing discrimination against our patients, our colleagues, on the basis of this pregnancy, parental leave and return to work must stop. 1 in 2 Australian women report experiencing discrimination. That's half of our patients, half of our colleagues. 1/4 of male patients and colleagues, despite them only taking very short periods of leave, also report experiencing this discrimination. I encountered pregnancy discrimination well before becoming pregnant. I asked my head of unit for a reference for a fellowship that I was applying to, and he felt compelled to ask me before writing the reference whether I was pregnant or planning on becoming pregnant during the period of the fellowship. It had not occurred to me that writing a testimony to my surgical skill, my character and my expertise would need to take into consideration my conception plans for the coming years. And indeed, nor should it. I was delighted last year to see the then AMA New South Wales President Brad Frankham stand up and write to AMA New South Wales members and also be on the front page of the Sydney Morning Herald calling out this discrimination, and also for Victorian board members to support a motion to eliminate such discrimination. Pregnancy discrimination can have devastating effects on health and on economic security. It can affect a woman's ability to attend for prenatal care and is a risk factor for postnatal depression and anxiety. Further, a doctor's training should not be compromised through the taking of maternity leave or parental leave. The inability to complete a pre-vocational training program, for example, if maternity leave is taken, bears a significant and disproportionate impact on a medical officer because it prevents the obtaining of unconditional registration, and similar problems arise with vocational training programs that are required to attain specialist qualifications. So the Federal AMA must make it clear that it will not tolerate discrimination in the medical workforce and that it is supportive of working parents. So I call on National Conference to support the motion.
Thank you. Microphone one.
Thank you. Christine Beverthausen, I'm from Victoria, and I am an obstetrician, which is apparently not a good training program to get into, or hard to get into, and I would agree with that. I rise in support of this motion, but I don't think it can be taken in isolation. Over the years, I've certainly seen how public hospital work, I speak as a VMO now, how public hospital work is much more becoming a service industry and not a training industry, and how the pressure to have people doing the job is much more important than any learning they get. In my job, every week we would have times when shifts aren't covered, theatre sessions aren't covered, clinics not covered. We are told that there isn't anyone who wants to come over to do it. We are told that getting a locum is not hospital policy, and we are told that we then have to cover the shift. I think that this has to be addressed, but it has to be in conjunction with speaking to hospitals and employers about workforce issues in general. Thank you.
Thank you.
Janice Fletcher, paediatrician and genetic pathologist. Actually, what I wanted to say segues into what Christine just said. I think, Tessa, could you consider changing your second dot point to say, rather than calls on, to say works with?
Mm-hmm. So Janet, point of information, this is not a binding motion. It'll go, if passed, to Federal Council with the changes such as those.
And the other thing I wanted to say is, can you put a part C that says develop improved employment models for doctors in training?
Yep. All right, one last speaker.
Thank you for indulging me for one last point, Shanaz, General Surgeon and Rural Doctor. The elephant in the room, that this issue keeps on going. Even once you've finished your training, this affects younger fellows, and it affects you when you negotiate your contracts. I was systematically dogged by our health district to try and sign up to a different contract to the rest of the surgeons. I wasn't offered a rural doctor's rates for rural work, unlike the other people that I worked with, the other men, I'll be often honest, and it keeps following you through. So to me, this continues to create issues such as the pay inequity. When are we going to address this as an association? Why is there a gender pay gap in medicine? The MBS doesn't have a pay difference for your gender, and yet it exists. We know it's 36% in medicine. I know it's 57% in surgery. How is this possible, and what are we doing to investigate it?
Thank you. Last words, Tessa? No, all right. So we'll put the motion. Voting's open. I think we should go ahead then. Right, and the motion is carried. Okay, so we're just going to vary it because Tessa's had a long time on her feet just then. So we'll move to number 14, access to the National Disability Insurance Scheme for people with psychosocial disability. And the motion is that our AMA supports access by people with a mental illness to NDIS assessors with appropriate skills in psychosocial disability and cultural awareness, and calls on the NDIA to ensure that psychosocial disability is given the same weight as physical disability for the same degree of functional impairment. Moved by Steve Kisley, seconded Gary Galambos. Thank you, Steve.
Again. Hello again. Hopefully this is going to be a bit less controversial than my previous motion. Basically, mental health services are a mess. We spend lots and lots of dollars for actually very little benefit. So often, you know, people like Greg Hunt will get up here and say how much money the government is spending on mental health. Often it goes for non-evidence-based programs such as Headspace, which is basically distraction therapy for the worried well. Mental health is the only specialty where the care for the most complex and most severely disabled patients is subcontracted to non-governmental organisations. Now what little support our patients got from these NGOs has now been hoovered up into the NDIS. And why is that a problem? Because the NDIS is an insurance-based program that replaces the block funding that was previously available to NGOs to look after patients with severe mental illness. Your access to these programs is now solely through the NDIS after you've had an assessment. The assessments are based on function, not diagnosis, and the mental health, if you like, A-list doesn't even mention mental health problems as one of the illnesses or conditions that they're likely to fund. Assessors are far more familiar with assessing physical ability than psychosocial disability. And the key thing is this issue about permanency. So for the NDIS to take a patient on, the disability must be permanent. They allow a certain degree of fluctuation, but they do not allow any recovery to substantial social functioning. That actually disadvantages a lot of our patients who actually can make quite good recovery, although they may be prone to relapse. So there's a large number of people who show partial recovery and then relapse who are not eligible. And this covers many psychiatric disorders. Even if they get a package, clinicians actually have no say in what's provided. In the old days, we could at least discuss with the NGOs what sort of aspects would be in someone's rehabilitation program. Now we have no ability to do this whatsoever. I had one patient who was unable to budget, barely able to survive, who after being accepted onto the NDIS was offered a Jamie Oliver cooking class. That was sort of really, not really terribly relevant for his needs. We must ensure that psychiatric patients who don't meet the NDIS's criteria get the services they require. In Queensland, we've had to rely on the fact that the government has thankfully provided some interim top-up funding to cover these people, but it's basically a once-off and there's no guarantee of recurring funding. So I'm asking the AMA to give a clear message to the NDIA that psychosocial disability is as important as physical disability, and to make sure that patients with complex needs are not left to hang out and dry. Thank you very much.
Thank you. Those speaking for the motion, microphone 1. Against, microphone 2. Thank you. Microphone 1.
Thanks, Bev. I'm Danielle McMullen. I'm a GP in Sydney. I'd like to speak in favour of the motion. I think the NDIS as a policy has been aspirational, but there's significant gaps in service. I see a lot of patients with chronic and complex mental health and psychosocial needs, and I must say I've been disappointed so far by the response and support for us as doctors from the AMA and other medical groups. I think traditionally disability and NDIS fell within the disability services and was seen as not a health issue. Now as doctors, particularly GPs, and providing those access request forms, we've been dragged into this, and we are the gatekeepers in a way to helping our patients access service. So we really need the support as to how to learn the new language, be able to perform functional assessments or at least collate information about those so that we can best support our patients to receive care. But echo the thoughts that even if we can do that at the moment, there are significant gaps for these patients in particular. Thanks.
Thank you. Microphone 1.
There are some people who just need no introduction, aren't there? Okay. Okay, so I run an addiction practice. I look after a lot of drug addicts. I look after a lot of street people, homeless people. I look after a lot of people with mental health. I also treat ordinary people. About a third of my practice is conventional, normal human family practice. So I see the ladies or the gentlemen who get an attack of the vapours because they're getting an attack of the pimples. So I see the worried well, and anybody who's going to try to give any sort of benefit for mental health really has to decide, are they at the worried well end where they don't even need a Valium, they need 5 minutes counselling, or are they at the far end where they've got an ice-induced psychosis and will never, ever be normal? The people who are right at the far end of the spectrum often fall between the cracks. They can't even fill out a Centrelink form. They go into Centrelink and Centrelink says, go over to the computer over there and fill out the form online. And they've got no idea how to. They can't organise their brain 3 minutes long enough to fill out the form. They fall between the cracks. These are the ones who desperately need assistance from facilities such as NDIS. We're going to have a lot of definitional problems about separating out those who do and those who don't need assistance, but I strongly support this motion.
Thank you. We'll go now to microphone 2.
Brad Horsburgh, ophthalmologist. Whilst I laud the humanity involved in this clause and this motion, I think it is naive in the extreme. I remember when they launched the NDIS, it was the Gillard government, the then health minister was Catherine King, the opposition spokesman was Mitch Fifield. I was in the room, there were many people, including many journalists in the back corner. And Catherine King stood up and said, "This will be wonderful, it is a seminal event. We can care for 250,000 people." 5 minutes later, Mitch Fifield got up and said, "There are 2 million people in Australia who identify as disabled." And not once, no one asked the question about the mismatch between expectations and finance. If you want a highway to the same sort of outcome as the New Zealand no-fault compensation scheme, you'll see what they did with autism. It has blown the numbers out of the water. I laud what they think, but it's not fundable.
Thank you. Microphone 2 again.
It's interesting we're not going from for and against as one would normally do in debate, Chair. Anyway.
Well, there are no normal rules in debate, so thank you for your contribution.
Standing orders. So, Chair, I stand against this motion, not because I don't feel that there is clearly people with a need, but we already know the NDIS is failing because it cannot sustain the current demand. It was originally brought in place, for those of us who have been around long enough, in response to uncapped risk for severely disabled children who were born during our attempts to manage the insurance disaster that was faced, and Andrew Pesce's in the room who prosecuted that debate so well. And that was fundamentally because physical disability costs enormous amounts. Then mental illness, understandably, was added to that, but that was an additional 56 million or billion or whatever the figure was. And now we want to go to psychosocial sort of matters, which is almost impossible to define. I don't think this is manageable. I don't think we should be prosecuting it. And I think that we have to find other ways to manage the very complex people who are falling between the gaps. I urge you to oppose this motion.
Thank you. We'll go to microphone 1.
Yes, Bill Pring, psychiatrist from Melbourne. I speak in favour of this motion, but I take on board some of the things that have been said by people previously. I think that the AMA does need to get really quite involved with this issue rather than leaving it be. I think there's reason to believe that the program is virtually corrupt as it is at the moment, from my experience as a psychiatrist and a number of my patients receiving payouts as big as $50,000 for one of my patients who has been managing quite well at home with the care of his GP and his psychiatrist, and will need more services later on, I think. But I think it's also really one of the main things here is that it's going to muck up mental health care further than it already is, which I've heard plenty from my colleagues over the time here of how bad mental health care is in Australia, and I know that myself. And so this is going to just make it even worse. So I think we need to vote for this motion to get this on the agenda for the AMA, to make sure it doesn't muck up mental health further. We've got to include psychosocial disability in there, shouldn't be left out. But what's been left out is the medical side of it. It's virtually impossible for me to have any significant discussion over my own patients. The person that got $50,000 has been offered 14 counselling sessions, no reference to me. 14 counselling sessions paid at $270 an hour for a counsellor. So I'd urge you to vote for it. There's one small alteration which in the furtherance of time might come through, and that is that I've spoken with Steve about, and that is to put in NDIS medical assessors rather than just NDIS assessors.
Thank you. Microphone 1, and then we'll finish with 2.
Hi, I'll keep it short and sweet. My name is Caroline Crabb. I'm a psychiatrist practicing in a public hospital in Perth. I would strongly endorse this motion. I think that we have so many patients in the community in Western Australia with varying levels of mental health difficulties and severe medical comorbidities, including substance abuse. And I would urge the AMA to assist us with better coordinated integration between the NDIS and psychiatrists. Thank you.
Thank you. And now.
Hi, I'm Dr. Helen Schultz. I'm a psychiatrist from Melbourne, and with total respect to Dr. Pring and to Dr. Kleisley, who've placed this on the agenda, I do feel that by supporting it, I'm also supporting a very sick system where our psychiatric patients don't belong. Our psychiatric patients deserve to have the old form back. They deserve case managers. They have severe and complex mental illness at times. They cannot navigate the NDIS. They cannot advocate for themselves. So I think by supporting this motion, we're actually forgetting that we need to still campaign for independent mental health funding. That's what our patients truly deserve. They won't get the NDIS funding anyway. We've already found out that a lot of people with autism won't be getting it. I can't see how, if we go along this path, we're not actually taking away from an opportunity to get what we used to have back.
Thank you. And last speaker. Thank you.
G'day, Antonio Didio, GP here in Canberra. Several of the most anxious, depressed and unwell patients that I've seen in the last year or so have been employees of the NDIS. I support very much the decency and goodwill of the people who have brought this motion, but cannot support the organisation that we are entrusting to do it. This is an organisation that has had an astounding 45 to 48% staff turnover in 1 year. If you don't like what they're doing, wait 6 months. I don't trust the NDIS at all. Thanks.
Thank you. Steve, did you want to respond? And you've got a minute.
I think I'm very saddened because I think some of the comments reflect the stigma that people with mental illness face, because I think people are missing the point. People with severe mental illness aren't going to be getting any extra money. The NDIS is at risk of taking away what little supports they have because they can't get access to the NGOs. And I would remind someone who said psychosocial disability is actually due to mental illness. There may be a debate about the level of functionality and the threshold in general, whether that's physical or psychosocial disability, and the affordability of NDIS. We have to make sure that people with psychosocial disability have the same function, get the same level of service. I agree that the NDIS is not a well-functioning machine, but the fact of the matter is we're not going back. I'd love to go back to the old system where NGOs were funded directly, but we're not going back. We have to live in the real world, and we have to deal with NDIS and the consequences of NDIS, and we have to make sure that psychiatric patients have their levels of support safeguarded. I urge you to support.
Thank you. Well, here's the motion. Voting is open.
When's that?
So the motion is carried. Thank you.
When's that? Isn't it now?
So it is afternoon tea time. Now, and I think we've got the candidates have got, are the candidates presenting again at afternoon tea? Yes. Yes. Okay.
Yes.
Yes, I think. Well, Bev's is working, so I'll use hers. It's just coming up to afternoon tea time. We will break for absolutely no more than 30 minutes. The rural doctors have asked to also have a candidate briefing. They're going to be meeting in the Speakeasy, which is the barber shop on the ground floor just before you exit to go around to the afternoon tea venue, so everyone else can go to the Eureka room. Rural delegates can go and listen to the candidates in the Speakeasy, please. And please all be back here on time at 3:45. We've still got a fair bit of ground to cover before the urgency debates at 5. Thank you.